Hey there, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. And if this is the first time you're listening to the podcast, well, thank you for choosing Let's Talk Micro as one of your podcasts. I know there's many out there, so thank you. And I know you're eager to listen to collaborations between the Micro Lab and Stewardship, so I'll be brief. I'm just going to say a few things and then we'll jump to the episode. Hopefully, you stay tuned on the last episode and you heard that we reached the 200,000 downloads. So that's such a milestone. I am so grateful. So thank you for the support. Okay, so today's episode is about collaboration between the microbiology lab and the antimicrobial stewardship team. And in the episode, I am joined by Dr. Erin McCreary, which she's one of the hosts of the Breakpoints podcast. And I am also joined by Dr. Hannah Creager. And what can I say? Such a great conversation. So let's go ahead and listen to it. And just so you know, this is part one of a two-part series. If you work in the lab or you're a physician, an infectious disease pharmacist, or anyway, people that work in healthcare, you know that communication is very important. Successful completion of projects and things like that it's very important depending on good communication, good collaborations. So I thought it would be good to do an episode about that. This was one of the talks that I caught when I was attending Mad ID in Orlando. Shout out, it was a great conference, first time attending, and I reached out to the speaker, and today I have two guests, and they're going to be talking about collaborations and communication. So with me, I have Erin McCreary and Hannah Creager. Everyone, welcome to Let's Talk Micro.
Thank you.
Thanks for having us. Excited to be here.
Definitely a pleasure. So let's go ahead and start with a quick introduction about what you do and anything else that you want to share with the Let's Talk Micro audience.
Hannah, do you want to go first? You want me to go first?
You can go.
See, good communication we have here. Well, I'm thrilled to be here. Thanks for having me, longtime listener of the pod. My name is Erin McCreary. I'm an infectious diseases pharmacist at the University of Pittsburgh Medical Center. I have the honor and privilege of working with all 37 of UPMC hospitals. And I think the way this derived, and I'll let Hannah introduce herself, is that we are doing a better job at functioning as a system recently. And we've really started to work together to bring our main lab, which is in downtown Pittsburgh, in connection with all of our labs across the system, which we have 20 something micro labs across the system, and trying to get everyone to report things the same and work together. So I've spent the better part of the last 18 months working with the labs on how we can improve our collaborations with our stewardship teams. And it's been just really, honestly, the coolest project ever. So we're really excited to be here today to talk about it. And with that, I'll hand it over to my partner in crime, Hannah.
Yeah, I'm Hannah Creager. I am one of several medical directors at our main academic medical center. We also serve several other local Pittsburgh area labs. I'm in charge of bacteriology, so hence kind of probably talk the most with Erin. And I'm also in charge of our laboratory at our children's hospital. Erin was originally more at our academic medical center, and so I work very closely with that stewardship committee, and I knew her from that, and she has transitioned into more of a system role. So there are a lot of other people in micro that are involved in all of this work. It's not just me. I want to give them a shout out, but I think we didn't want to have like 20 people on the podcast. So Erin very kindly invited just me. And I'm obviously involved because since we are the big academic medical center, a lot of, not everything, we're also changing and fixing a lot of our practices. But we're sort of leading the way on a lot of this stuff. It's sometimes things that we've been doing locally for a long time that we're then trying to spread to the rest of the system. And like I said, sometimes they're things that have been on my list to clean up, and then we get to clean them up all at once for everyone.
Yeah. And that's a good clarification point. So I take care of patients, and my clinical practice is at our main hospital, which is Hannah's main hospital, one of Hannah's two main hospitals, actually. But then we help people take care of patients at all of our hospitals. And I will say, no one can explain to you a package insert limitation on an automated susceptibility testing machine quite like Hannah can. So we're gonna learn a lot today. When I, as a clinician, am like, why aren't you reporting ertapenem? And she tells me everything there is to know about why we cannot report certain drugs. So
I definitely love myself a good package insert, and what a pleasure again. So thank you again for taking the time to be here. So let's go ahead and jump right into it. And as I said before here on Let's Talk Micro, the audience is quite varied. So we can have anyone from maybe like a student to someone maybe just starting to work on the field. And even the experienced one, sometimes we get so focused on the bench and right, we look at our workload in micro and we're like, oh my goodness, I'm going to be here all day. And that's the sole focus. So sometimes listening to other things outside of the bench, some people might not be such in tune with. So let's start with some basics here, so they can get some background. When we talk about antimicrobial stewardship and their goals, can you talk more about that? Like, what is antimicrobial stewardship, and touch on their goals?
Yeah, I can take that one. And then Hannah, please fill in. Because I will say, of all the micro lab directors I've had the privilege of working with, Hannah and our team. So, like she said, she represents a lot of really fabulous people. They all get it. And I love that. They all want to appreciate how the results that the lab is putting out, how clinicians are acting on those results, and then ultimately taking care of patients. And, things that might make really good sense to the lab technician's brain might make zero sense to a neurosurgeon, right? And so it's like, how do we get our brains to think the same way and to interpret things the same way? So, antimicrobial stewardship at its core, the definition of it is a coordinated set of interventions. And I think that's an important aspect, coordination across multiple parts of the care team, right? In order to essentially get the patient on the right antibiotic, so antibiotic choice, at the right dose for the right duration, and really just optimizing everything about antimicrobial use. And sometimes that is nothing. Sometimes stewardship is the patient needs no antibiotics, and sometimes it's escalating. Sometimes it's, oh my, they have an ESBL and we didn't know that till day 4, and maybe we could work together and have a better way to determine they have an ESBL in their blood on day 1, so we can escalate their therapy. Perhaps they need broader spectrum, and everything in between. So that's really what we're talking about when we talk about stewardship, is judicious use of antimicrobials in all patients in all care settings across every member of the healthcare team.
I think that's great. And I would just say, from the micro perspective, we love working with stewardship because there's a lot of subtleties in interpreting microbiology, and particularly in terms of how it drives treatment, right? There are things that are important in one patient and they're not important in another patient. So I have to report them because I don't necessarily know, and we have a lot of patients. But it's really nice for me to know that stewardship's out there, because maybe I want to write a 1-page comment on my report about, what you should make of this. I can't do that. Ain't nobody going to read that. So having kind of interpreters out there, with a lot of the folks we work with, particularly stewardship, is really helpful for me in that regard.
Well, that was great, and thank you for that. So when it comes to collaboration between stewardship teams and microbiology labs, why is that so essential?
Man, I'm sure. I'm sure.
How could you not?
I know. Well, one, who wouldn't want to be friends? I mean, I low key love the lab people. I'm so jealous. I wish I was one of you. I randomly wander into their offices sometimes just to hang out with them. I guess Hannah and I are probably gonna have a similar answer, but from different approaches on why collaborating with their side makes our work just so much better. I'll give a good example. So we are in the midst of a massive electronic health record conversion across our enterprise. So UPMC, for those who aren't as familiar with the system or who haven't heard me talk about this before, we currently operate on 9 different electronic health records across our inpatient and outpatient care settings. And 9, it might actually be 11. I think we miscount sometimes. And so we are converting to a singular entity, which is tremendously awesome and also daunting. And admittedly, a lot of what spurred us to really connect and collaborate is this transition, because when we made this transition, we said we are going to write a singular set of rules in the electronic health record, right? We are going to report antibiotics, antimicrobials the same way. If you have pneumonia in this part of the country and you have pneumonia in this part of the country, you should receive the same care. So how can we all get together, and then how can we coach and train our community labs and clinicians? And honestly, how can we coach and train our academic labs and clinicians? Because we all have our own little biases and our own little ways to do things, and we all have a lot to learn from each other. So that's how this partnership really started. And I think one of the best examples of why the collaboration is so important is I'll use a clindamycin example, because this is a time where Hannah really taught me a lot. So from a stewardship perspective, we don't love clindamycin. Hate is a strong word, but I would go so far as to say we hate it. It's an antibiotic that has very little in vitro activity against things you care about, and it causes a lot of toxicities. Notably, it's really, really associated with Clostridium difficile infection, and nobody wants that, right? So we try to avoid Clinda at all costs. And so when we were talking about how we wanted to report our gram positives from the pure antibiotic steward clinical brain, I asked, can we suppress clindamycin on our streptococcus species if it's susceptible? So just don't show it to them, out of sight, out of mind. They won't use it if they don't see it. But in case someone's like, oh, I use Clinda for everything and I just assume it's susceptible, that's where we can run into harm. And I do think it's pretty important that if something is resistant, that you report it, right? So that people don't assume it's susceptible and use it and cause harm. So I was like, let's suppress Clinda if it's susceptible, report it if it's resistant. Hooray. Cross it off the list. That's so easy. We are good stewards. We've helped so many patients. Well, Hannah comes back and she's like, well, Erin, that sounds great in theory. And I'm so glad Stewardship wants that. But she's like, half of the labs in the system aren't performing clindamycin inducible resistance testing. And that would be something that's a little higher technical challenge. It'd be something they'd have to validate on top of all the other things we want our labs to do. She's like, how important is this to you to prioritize? The labs can only do so many things in a day, right? So do you want everyone now to make sure we're doing Clinda resistance testing on every isolate? Because that's not something we do right now. Or can we just not do this and can we just suppress it across the board, or can we report it across the board, right? Like we had to come up with a harmony. And that I love that example because it's like where the lab taught me about their workflows, the different tools they have at different lab sites, what it takes to report something as susceptible and resistant for different things. And of course I knew about inducible like resistance testing, but I just kind of thought it got done. Like I just kind of thought it was a thing that automatically happened, right? And so that's where the lab can teach me so much about the capacity they have, the technicality of different things. And then we can come to a decision together that's going to be the best compromise of we're getting what we need out of trying to support good antibiotic use. And the lab is supported in that we're not constantly asking them to do things that are super time consuming, super tedious, super hard, whatever, if there's not a lot of clinical gain. So that's one of my recent examples.
I think that's a good one. And if anyone's wondering, like, why the split with inducible clindamycin resistance, some of our labs test manually. Some of them use automated panels for their streps. And some of those automated panels do not have, like, all of the panels for testing staph, for example, have an inducible clindamycin resistance test as part of the panel, but does not apply for everyone for strep pneumo. And so we would have been having to set up the manual test, which would take another day, which is the D test. And then we kind of, I think we went back and forth on this one because I actually then said to Erin, well, we could just report it if it's resistant without the inducible clindamycin resistance test, but then and this is, I think, why I want to work with Stewardship, right? Because they're much more in the behavioral and they see what clinicians do, right? Like learn from Stewardship that anyone would think it's a good idea to use an antibiotic that just flat out wasn't reported and assume it's susceptible, but I've learned that from them. And so, I said we could do this, but if people then get used to the fact that it's reported when it's resistant, so if it's not reported, I'm just going to assume it's susceptible, then I don't like that either. And so we actually had a little bit of a discussion about this one, and we kind of settled on, okay, we're not going to report. If someone calls and asks for it, we'll make sure that we do the inducible clindamycin resistance test if we don't have it already done. And that will be that. That's a great example, actually. But I was just going to say, generally, I appreciate Stewardship because I know sort of like what is and isn't a concern. First of all, I learn a ton of clinical medicine from them and from all of my infectious disease colleagues. I'm kind of, I think probably most of you know this, but in the clinical micro lab, the director is really a little bit unique in that we have more clinical training versus a lot of the technologists, that it's very much, it's limited to the lab, right? And so my job is to sort of act as a translator and bring the really technical micro stuff together with sort of the clinical implications. So they teach me a lot, as I said, but then also I can ask things, are people doing this? Is this, there's certain things that are inappropriate that at different hospitals, it doesn't occur to anyone to do. They're not a problem. And then at other hospitals, they are. So, for example, when I first got here and I started at Children's Hospital and rifampin was being reported on staff with no comment. And If anyone doesn't know, you don't want to use rifampin as a monotherapy because there's mutation and you rapidly get resistance. But it's oral. And so I was, immediately told, or fairly immediately told, by the ID physicians over there, this is a problem because people are seeing it get reported and they're trying to send someone home on rifampin monotherapy. Can you please add a comment that this is not for monotherapy? And I said, oh, of course we can do that. So we added that comment. And then I went to Presby Stewardship and I said, oh my goodness, I actually realized that you don't have that comment either. And Presby Stewardship said, no one wants to touch rifampin with a 10-foot pole unless there's stewardship or ID. We don't have any sort of problem with this. So it's really helpful. And, I can speculate and Erin's probably, used to this. I'll go and I'm like, so I can see clinicians doing this or this. Which one is it? And I get an answer to those questions. So I love that. And I also love that it's, as I said, they're kind of, stewardship is like an extension of the lab a little bit. And I feel like I said, I can work as a translator, but I think good stewardship also does that, right? They help explain what our results mean to people and what those treatment implications are. And I feel really good about that. This is more, different stewardship programs, I think, are different levels. There's sort of hands-on, hands-off. They're pretty hands-on here. And I like that a lot because, if we get something like we have a carbapenemase, right? The lab tech, so this is just to sort of break down how these things work, right? The lab tech's going to say there's a carbapenemase. And if we have certain resistance mechanisms, they get an alert. Hey, you've got to talk to the medical director about this. You need to set a carbapenemase test. And if they get a carbapenemase, they have to tell me. Okay, the first thing I'm going to do is look at that chart and see what therapy is the patient on, right? If the patient's on woefully inappropriate therapy, I'm going to call that clinician. There's very few things like this that we call, but I do it for carbapenemases because time is of the essence, especially, sometimes it's a UTI and sometimes, honestly, I look at the chart and the patient's on termsulfa and it doesn't matter. But if it's a CSF or a bloodstream infection, some of these, it's really important for them to know. And I don't want to, if they're only checking the chart once or twice a day, I want them to be able to change that therapy immediately. So usually if infectious disease is involved, I just call that physician. But sometimes, whatever the primary team is, I've had experiences where you call and you say, this is a KPC producer. And they say, what? What's a carbapenemase? Or how do I treat my patient? And that's a situation where I'm great at recommending treatment in a test tube. If your patient has contraindications, those sorts of issues, I can't tell you that. Again, I've gotten better about it because I've learned from my colleagues, but I'm a PhD. I really should not be getting into the details of treatment with you. And so having a relationship with stewardship where I can either refer whoever I'm talking to, or I can call stewardship and I can say, hey, we just reported this. Can you maybe intervene with them? And then that's really helpful to me because otherwise I'm having trouble sleeping at night. That's an extreme, but you're just wondering okay, I did the result. Is that patient getting the appropriate care? And so knowing that follow-up is happening makes me feel a lot better. And it makes me not feel like I'm being pressed to do stuff that's really outside of my scope of practice.
Yeah, and I'll say I think Hannah probably does lose sleep at night. She cares deeply about patients, which is fantastic. I think we both do. And a good example of that is, from the lab perspective, when we were writing our rules, I'd say, okay, the new panels have the newer beta-lactamase inhibitors on them. So they have ceftolozane, tazobactam, ceftazidime, avibactam, depending on what panel and what platform you use, right? And then, so it might be easy to write a rule that says we'll never report ceftazidime, avibactam unless there's a KPC or an OXA found because we shouldn't use it. And then as a steward, I'm able to come in and say, well, actually, there could be a case where a patient has a really terrible seizure disorder. They're on valproic acid. They have an ESBL in the blood, and they might need ceftazidime, avibactam instead of meropenem because I'd want to avoid a carbapenem in that situation, which is a clinical drug interaction that really has nothing to do with lab technicality, right? And so we actually have a really cool Enterobacterialis cascade that takes that very situation into account where a lab technologist is not going to be able to know that clinical detail, but we've actually been able to come up with a reporting pathway that allows us to release results in those settings. And I think those collaborations are very cool and why I think the microbiology stewardship communication pathway is just so crucial. I realized in our explanations, Hannah, too, and if I could take a moment for our listeners, it's probably best to step back a bit and talk a little bit more about UPMC's framework, because some of you may be listening and say like, well, why are you factoring in 7 different scenarios? I'm one hospital and one lab, and I don't have any of these problems, and I communicate with my micro lab every day because they're right down the hall. And if that's you, that's awesome. You're really lucky, right? If you're a small shop or even a big shop, but an enclosed shop wherein your lab is on site and your lab services 1, maybe 2 or 3 hospitals, and you're a pretty close-knit network, I hope you have really good communication, right? I think increasingly across America and certainly globally, we are systemizing in that, one lab may service 7, 8, 9 hospitals, or you might not have an on-site microbiology lab at all. Almost all of your testing is reference testing, or you're regionalizing some of your testing. And that's the world we live in at UPMC, where we have less labs than we have hospitals. All of our hospitals have access to a microbiology lab, but not all of them are on site. And then when we look across our footprint, we have every version you could ask for. So some of our hospitals have Microscan, some have Vitech, some have Phoenix of the main AST platforms. And then in those, some have MALDI to do identification and some do not. So the most standardized our system can be is 6 iterations of susceptibility testing rules, because we have 6 different panels. And honestly, one of the first thing that we collaborated on, we being Stewardship across our entire enterprise and micro across our entire enterprise, was ensuring that every lab was on the updated breakpoints with the most appropriate panel. And the stewardship teams went through all the panel offerings from each company and picked the panel that we thought served our patients the best. And then we asked the labs to adopt that panel based on what platform they had, if they weren't on that panel already. And then if they were already on that panel, we said, that's cool, but we have to make sure we go through and make sure all your breakpoints are validated. And that was like truly what we spent the end of 2024 and the beginning of 2025 doing. And that was a huge lift, but such important foundational work to now do all the other cool projects we want to do. But so just for the rest of the podcast, when Hannah and I might share some stories, if you're listening and you're like, what the heck? That's why. So in a best case scenario, when Hannah and I and our team, we sit down to write a rule, so to speak, we have to think about the 6 different versions of what we are trying to accomplish based on those 6 different package insert limitations for the 6 different panels we run. And that's just gram negative, right? Then we also have that on gram positive side. So maybe our degree of collaboration is a little intenser because we have had to, I truly feel like Hannah has taught me about every single platform and I think I can recite to you the cards and their numbers and what antibiotics they have and their limitations at this point, because we've gone through so many iterations.
Yeah. And I think what's great about Erin and a lot of our stewardship staff here, I hope everyone is this lucky, is that like they actually want to learn that stuff about the lab. So when we started on this project, it was like, gosh, your academic medical center uses current breakpoints. Like, just tell the other labs to use current breakpoints. Why can't we do that? And I said, oh, well, and I'll explain it very briefly if there are micro folks that are not familiar. But companies are now required to use the FDA breakpoints. Some of them are grandfathered. They're still using CLSI breakpoints. But if they've recently gone through the FDA, so if they want to update their breakpoints, which they also, not all of them have updated their breakpoints. But the point is, if we want to use a different breakpoint than what that instrument went through the FDA with, that's considered off-label use. So that is technically a laboratory-developed test or an LDT. It requires an off-label validation. That's something that honestly, I think anyone in an academic medical center will tell you that this is a pain to keep up with because breakpoints are changing, which is great. But it's, pulling together and getting the isolates for these studies, and it's just, another thing to do. But we have a whole virology lab that's running LDTs all the time. A lot of these community labs, right, they're not doing anything off-label. And so, fortunately, this was the case where I could, we explained to pharmacy and they were very appreciative. Yeah, we really wish it worked like that. It doesn't, but then we worked out a plan, and one of my colleagues worked very heavily on adapting validation plans for a lot of the hospitals in the system, and sort of centrally leading that process. And so I really appreciate, they understand that. And I think it's sort of, collaboration definitely builds on itself, because it's like, well, now I've had that conversation with Erin. So the next time something comes up and I say, that's actually really complex from a lab regulatory perspective, she's kind of like, oh, I've heard that one before, like kind of has some sense of what that is. And so I think then we both kind of understand each other better, and we're both able to work together better.
Well, that was such a great explanation. I can really listen to both of you talking. You have a great thing going on with your communication, and by now, you have shown how important it is. What both sides, bring, and things like that. And like anything, right? There's always challenges, and you mentioned all the different labs. I can't even imagine how challenging that can be. I work for one where micro, that's just the one place, and we receive everything from other places. But I have been in other places where they're part of a network, and you have 3 different labs doing microbiology. So when it comes to collaboration and communication, any have you encountered any barriers? Can you talk about those?
I definitely think, sort of as Erin said, the fact that we don't work in the same building, we're not down the hall from each other. I'm busy, but Erin, you look at Erin's schedule, right? Like, she can be hard to get time with. And so building those relationships, I think it doesn't happen. I think they'll also share, I think one of the things for us that has been huge is we actually started holding a monthly meeting that is kind of our micro stewardship work group. And that's for us, that's for the system. So on a local level, I can tell you also, I go weekly or every other weekly to stewardship meetings in our academic medical center and our children's hospital. And then there's usually quarterly meetings at some of the other hospitals we serve, and I go to those. But then to do all the system stuff, which we've never done, and we had no kind of place to do it, we started this recurring monthly meeting. And that's a great opportunity, so it's stuff comes up that if that could come up on the meeting. And I think we really started with that. And then because we have very much of a working relationship from that, stuff comes up in between meetings, and I'm like, oh, I need an answer in 3 days. And I can ping Erin and be like, so we need to discuss this at our next meeting, but now this is what I need. Or if they're kind of smaller things, because again, we're kind of both current with what each other is doing. And so then you can have a lot faster of communication rather than starting from square one. Well, I have to explain the whole thing, and I have to explain the background to you because you need the background of the background, and you're not familiar with any of that. So I think I love that meeting, actually. What I like for us, and again, not every hospital necessarily needs this, but it is a lab stewardship collaboration meeting. So I love going to stewardship meetings, right? Those usually happen regularly at our local institutions. I think it's great to have a micro director there, but they tend to be more focused on sort of stewardship. And for us, being able to have a lab component of it, and we also have additional lab-only work group meetings that we then use to sort of implement the stuff that we talk about in our lab stewardship collaboration meeting. But I think especially because we're trying to build a lot, in a way that, sometimes we're making more incremental improvements locally. I think having that dedicated time and space has been really good. I think the other thing that I'm really happy to see is, I think as a medical director, I'm sort of immersed in, again, that clinical side and the stewardship side. I know all that stuff. As I mentioned, for a lot of the technical staff, that's not necessarily their area of expertise. And we ended up this meeting, we probably invite a lot of kind of operational leaders and those sorts of folks at it. And, I'll be honest, sometimes this meeting is Erin and I going back and forth for 10 minutes about some sort of antibiotic resistance mechanism or this, that, or the other thing. But what I've heard from people is even they're like, well, I don't always understand everything you're saying, but like seeing that interaction and like having, I can understand half of what you're saying and having that context when I'm then going to my people and saying like, you need to do this study, you need to change this, that, and other is really valuable. So that was one where I was kind of like, oh, well, Erin and I can just have a meeting, right? And I think having that be a wider circle has been really beneficial.
Yeah, I would co-sign everything Hannah said. I was like I took notes down because I forget things. I was like, oh, I want to like, okay, so I'll try to be more succinct because obviously Hannah and I love to talk too. Okay, so I would say barriers to trying to build solid collaboration between microlabs and stewardship teams. And again, I'm speaking from the hat I currently wear, which is a director of a major system and trying to get everyone aligned. But I think you could also take these on a micro level, pun not intended. But you could take these on a smaller scale level if you're only representing one hospital. First and foremost is prioritization. So there are endless things that we want to do to take care of patients that we want to do for fun, right? We want to try unique nudges. We want to, I've said this on our podcast Breakpoints before, but the Henry Ford team just came out with the Say It Ain't Steno paper about steno nudges, which we've brought to our micro stewardship leadership meeting. We're going to adopt that nudge at UPMC, but that's something that's cool. It's great. We'd love to be creative and implement those kinds of things and publish about them. And when we see other centers publishing about them, we'd love to immediately adopt them. We simply cannot, right? So we've brought the Say It Ain't Steno paper through all of our committee structures, all of our clinicians, stewardship, microbiology labs are on board. That was a great example where the micro lab was like, oh, we could easily do this. We add this comment. We could even build it in our electronic health record so it's automatically added so the technicians don't have any work. So that's awesome, right? So that's something that I appreciate and learned from Hannah and team, that it's not a big lift for them and the timeline can be a little expedited, but we're still going to implement that in Q1 or Q2 of 2026 because we have a lot of other stuff going on in 2025. And even though it doesn't take that much time, it takes time and you can only do so much in a day. So if you're doing one thing, you're not doing another thing. And so something I'm very proud of is in this micro stewardship leadership meeting that we have at the beginning of the year, really the end of 2024, we determined we truly call it like, this is the work of 2025. And we set goals together. And it was everyone's going to get on the new panels that we've picked and validate all these breakpoints, which I learned, takes 8 months for the lab to do. And we set a few other goals, which is all of our labs are going to bring on ESBL disc testing. We were doing ESBL testing a million different ways. We said we're going to pick a way. We're not going to devolve on ESBL pro-con debate testing, but we said we're going to do it. We're going to pick a way and everyone's going to do it the same way. In the labs that have never done disc testing before, they're going to learn in 2025. And we support each other. We share isolates. We share expertise, which is really cool. And so we set 5 huge projects, 5 big goals, and that was the work of 2025. And then you have the daily fires that come up, right? You have a patient case where something was misinterpreted and you need to have a root cause analysis about that and decide if you need to change. You have breakpoints that are constantly being updated that we need to accommodate. You have new antibiotics coming out that we want to bring on susceptibility testing for. There's always stuff that comes up. But in terms of the big projects, I think we do a very good job of communicating with each other and saying, this is not one of the goals of 2025. So if we want to tackle this now, what are we going to stop doing? Or does this become a 2026 goal? Does this become a 2027 goal? And we actually have a few things that we've already earmarked for 2027. And so I just say prioritizing is absolutely the hardest to keep everyone sane. And then along with that, appreciating the time it takes to accomplish a project on both ends. So sometimes the lab is the rate limiting step. It takes them a lot more time than it may seem on face value. Sometimes stewardship is. Sometimes the lab has been like, we can turn this on tomorrow, Erin. And I'm like, wait, what? We're not ready. Some things I'm like, oh, okay. I'm going to give you guys 6 months heads up. We want this. What's it going to take? And Hannah's like, nothing. Do you want my text to do that right now? And I'm like, whoa, no, that I need to educate the physicians. We need to have lead-in time. We can't make that change until we're ready, but good to know it doesn't take that much on the lab. So the timeline on both ends is important to level set. And then along with that is the bidirectional communication. I think we do a really good job at UPMC. I'm really proud of the structure we have. I'm a big structure, process, outcomes person. I think if people appreciate where work gets done and who does it and can follow it along the process, then they appreciate the ultimate outcome. But as much as we've improved this, we still miss things sometimes, right? We'll talk about things in our micro stewardship leadership meeting, and then we have another meeting at our system, which we call our infectious diseases quality team, which brings together labs, stewardship, and then infection prevention. And sometimes after we talk about things in 2 or 3 meetings, we think everyone knows, and then we're like, oh shoot, we never shared this in the hospital operations forum or something. Like, you forget to tell a stakeholder group, even though you've done your very best to over communicate. It's constantly threading that needle, especially amongst a large system such as ours, and getting input from every site, because every site is going to interpret things a little differently, have unique needs, and you need to make sure you've thought of everything, but not having 47 people trying to make a decision, because then you'll never make a decision. So being nimble, but being inclusive is a challenge for sure. And then for us, it's a strength, and Hannah explained it nicely. I'm just so lucky, but I think your team can be a challenge or a strength, and you have to turn it into your strength. Like, you can't get anything done unless you work with good people, and good people can do anything. I always say it's not the actual work, it's who you're working with. And we're so lucky that like Hannah described, our people on our teams who are a little more technical, or some of our supervisors, or even some of our administrators, they're like so into and supportive of our super nerdy dialogue. And so it makes it just this really cool community where they are engaged, even if it's not something they fully understand, and vice versa. Like, there's a lot of things that I'm learning but don't fully appreciate about corporate supply chain, but I'm learning, right? And I'm learning, hey, you want to bring on this rapid diagnostic technology? Okay, well, here's the 8-month contracting pathway that the supply people need. And like, this test falls under microbiology, but we have a contract with that company for gloves. And so like, you also like the contracts are intertwined, right? And so if you're going to use less testing here, we have to buy more gloves, or we have to rewrite the contract, right? Because you could be in, that's a silly example. I don't think anyone makes gloves and tests, but maybe they do. But
the point is well made.
Yeah, like contract, like that's something I'm learning. Like, contracts are intricate, right? And then again, and then everyone in healthcare makes decisions with the best they can with what they have at the time. We have to believe that, right? So it's really easy to Monday morning quarterback, especially on a huge system. But you have to believe that the things are the way they are because someone did the best they could. And so if you're like, this contract is crazy, or why don't we have this? Well, because maybe someone didn't know, or maybe back then it was a good bundle, but now that test isn't as relevant. We probably don't have time to talk about this either, but UPMC just got rid of procalcitonin. Gasp. And so when we were like, we're not going to offer this test anymore, it doesn't impact patient care. We had to make sure that we thought we were going to save all this money by not sending the test. We had to make sure that like we weren't committed to a certain number of test volumes, right? Before we took a huge penalty kind of thing. So, which luckily we were not. And even if we were, we do the right thing for patients and we take the penalty, but you have to factor that into your whole business case. So I'd say those are my, maybe not barriers as much as, if you're starting a program, things to think about.
Yeah, that was excellent. And I'm out of curiosity, just when it comes to these meetings and things, and it's just me thinking, one thing, right, that with COVID changed was that we started doing more online meetings, and I'm guessing like the frequency, the ones that you do are mostly like that, or do you still do the traditional in-person meeting?
It's funny. I like in-person meetings, and so I still try to have them as much as I can within local settings. But I think, we're Teams users, basically use it as Zoom. But whatever platform you're using, the video meeting and just people being accustomed to working in that format, I think has been a huge, huge boon for health systems like ours, right, we're completely geographically spread out. There's no way that we would all be getting together in a room once a month. It would not happen. And so in those situations, I think, the ubiquity of teleconferencing has become incredibly valuable for us.
Yeah, yeah, definitely. I think it was for me. It was a little bit of adjusting. 'Cause I think it just like it opens the door to getting a little bit more distracted when you're doing the online thing. Because especially if you don't have your camera on, like you're working and you're kind of listening with one ear, checking something else, and the room kind of like forced you at least to appear that you were paying more attention because they were looking at you. So
Pretend a little bit. I will say we're a camera on culture, and I think that's something you have to set the expectation as leaders of the meeting is that if you're in this meeting, your camera's on because you're in this meeting. I actually, I have a lot of friends who do various different work across all different kinds of healthcare settings in UPMC, outside of UPMC, and uh, it is funny in our culture now. People will be like, "Oh, well, you have this meeting, but like you can still call me." And I'm like, "No, every meeting I'm in, my camera's on. I'm talking. Like I know I cannot do other things. Like I'm in the meeting and I'm present, and that's how it should be. We should act like that." Um, I mean, that being said, in person is fun. So, I mean, Hannah actually does monthly micro rounds. So we go to the micro lab, but that's clinical teaching rounds. But that's super awesome. That's a great way to get in person and look at plates together and talk about patients and things like that. Like that's invaluable. And you can't. I mean, I guess you could do that virtually in theory, but those are the kinds of things we try to keep in person.
okay, sounds good. Yeah, showing. I think that's another conversation, and teaching online, has its challenges, and I can definitely speak to that. I had to adjust myself, and doing that has its own set of challenges. Well, there you have it. I hope you enjoyed the episode, and I hope that you stay tuned for part 2. But this is very important, this collaboration between the lab and the stewardship team. And as you heard, Hannah and Erin, they have such a great working relationship, and their communication is great, and ultimately this helps the patients, which is the goal, right? So I just want to take a quick moment and really thank you again, because as you heard, at the intro and at the end of the last episode, we crossed the 200,000 downloads. So that is amazing, and that is all thanks to you. So thank you. As always, you can find Let's Talk Micro on all podcast platforms. If you go to Apple, Spotify, Amazon Music, Good Pods, we're right there. So please subscribe, download episodes, and if the app allows you to do so, please leave a review. Thank you for the support. You can also find us on socials on Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, X Let's Talk Micro 1, LinkedIn Luis Plaza, and there's an email address which is letstalkmicro@outlook.com. And of course, there's the website, letstalkmicro.com, where you can find resources, for taking the ASCP, for certifications, study resources. You can find updates on episodes, so please check out the website. But either via social media or via email, you can reach out with any suggestions, any feedback. Those are always welcome and appreciated. If you want to support us in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI. Both links available on the show notes. And if you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And as usual, those are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And my micro friends, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear audience, is the end of this episode. I hope you enjoyed learning about collaborations between the microlab and the antimicrobial stewardship team. As always, I enjoy sharing this information with you. And there's a second part coming. This was such great content. There's more information. On the second episode, we're going to be talking about nudges, cascade reporting, and their favorite bug. So please stay tuned. Please continue bringing that passion to what you do. It's so important. You do such great work. Thank you for the support again. Stay tuned. Great things coming your way. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.